Good afternoon, everyone, and thank you for joining us for this presentation on tardive dyskinesia. My name is Brad Hunt, and I'm the affiliate leader for NAMI Lubbock. NAMI is the National Alliance on Mental Illness. We're the largest grassroots mental health organization in the country. NAMI works to provide support, education, and advocacy for persons living with mental health conditions and their family and friends. NAMI offers free programming, including support groups and educational events like this one today. If you'd like to learn more about NAMI Lubbock, you can check out our website at namilubbock.org. As you may know, May is Mental Health Awareness Month, and this week, May 5th through 11th, we recognize Tardive Dyskinesia Awareness Week. Today, we'll be learning more about tardive dyskinesia and how we can support the approximately 600,000 people in the U.S. that live with TD. We're pleased today to be partnering with Texas Tech Mental Health Initiative, as well as the Texas Tech University Health Sciences Center. And I wanted to say a special thank you to all those who have given of their time to prepare and present the information today. Dr. Alog, Dr. Seif, Dr. Azmat, Dr. Nazir, Dr. Ali, and Dr. Trevino. And also a very special thank you to our guest, Athena, who's a person with lived experience with tardive dyskinesia, and we'll be hearing from her a little bit later in the webinar. Two quick housekeeping notes. If you have questions during the presentation, you can add those to the chat, and hopefully we'll have time at the end to get to those. And secondly, participants today will receive a survey via email after the webinar. Just a few short questions. If you don't mind taking a couple minutes and responding to that survey, we would greatly appreciate it. And with that, I would like to turn it over to our presenters. And thanks again for joining us for this presentation.
Hello, everyone. Good afternoon. Are you able to see the slides?
Yes, we can.
All right. So I'll begin. First off, let's start with understanding the meaning of the term tardive dyskinesia. It has two words, tardive, which means delayed, or symptoms starting later, and we have dyskinesia. This means abnormal. Kinesia is with kinetics, so movements. So in simple words, it means uncontrollable, abnormal, and repetitive movements of the face, torso, limbs, fingers, or toes, but it can involve any part of the body. What does DSM-5 tell us about the definition of tardive dyskinesia? It's involuntary. That means the patient has no control over these movements. Athetoid, which means that they are slow, writhing type, worm-like movements, or they can be coriform, which means sudden jerking or spasmodic movements, which lasts at least a few weeks, develop in association with the use of a neuroleptic medication for at least a few months, and persist beyond 4 to 8 weeks. So the duration 4 to 8 weeks is important to know because it differentiates it from a different condition, which is called withdrawal emergent dyskinesia. That tends to last only 4 to 8 weeks, and it starts after withdrawing from the psychotropic medication or sudden increase or decrease in the doses of the medication. Let's look at some of the movements which are associated with tardive dyskinesia. It can involve any part of the body, but these are some of the common symptoms which are seen in patients with TD. Rapid eye blinking, sticking out of the tongue, lip pursing, jaw clenching, twitching and jerking of their arms or legs, and muscles associated with breathing. So who is at risk of developing TD? We do have some well-established risk factors which are well researched. Those include older age. So the older the person gets, the more susceptible they are to develop TD. Antipsychotic dose-dependent response. That means the higher the dose of the medication, higher is risk of developing TD. And then also depending on the choice of medication. So depending on whether a person is on a first-generation antipsychotic, which examples would be haloperidol, versus the second generation antipsychotic, Examples would be risperidone, olanzapine. Important point on the slide is that while it's important to use the lowest effective dose to reduce the risk of developing TD, but TD can still happen. We also have some less research or less established risk factors, which includes the following: female sex, having a pre-existing mood disorder, having a cognitive disturbance such as dementia, having an alcohol or any substance use disorder, use of other medications like lithium or anti-Parkinsonian agents like levodopa, early occurrence of drug-induced Parkinsonian symptoms, diabetes, and HIV. Some of the medications that are associated with TD include antipsychotics. Examples could be both the first generation like haloperidol or second generation antipsychotics like risperidone, olanzapine. Antidepressants like sertraline, fluoxetine, venlafaxine. And then we also have a third class of medications which is associated with TD that includes antiemetics. That means the medications that prevents vomiting, such as metoclopramide. Conditions that are associated with TD include schizophrenia, bipolar disorder, depression, and GERD. Let's just understand whatever we have in the research as of now. How does TD actually develop? So we have different factors that are interplaying. These include the genetic predisposition, the dopaminergic system hypersensitivity in the brain, and then decreased functional reserve. Out of these, the most widely accepted theory is the dopamine supersensitivity hypothesis. Just to kind of simplify it, if a person is taking antipsychotic or psychotropics, that results in chronic blockade of the dopamine receptors. Over time, what happens as a physiologic response that there is increase in the number of the D2 dopamine receptors. As a result of that, there is higher expression of dopamine D2 receptors, and that results in the dopamine hypersensitivity and subsequent motor impairment. Dopamine is, just in simple words, it's a chemical released in the brain, and it is associated with regulating the movement. So that's how the dysregulation of the dopamine tends to cause abnormalities with the movements, along with other roles of dopamine. Okay. Some of the pointers or some of the concepts that we know based on this theory are that whenever we increase the dose of antipsychotic, it results in initial improvement of TD symptoms, but the effect is temporary. And over time, this physiologic response happens that will lead to, again, dopamine hypersensitivity and worsening of the symptoms. First generation antipsychotics are more potent, so they cause greater blockade of the D2 receptors. That is why they are known to cause TD more frequently than the second generation antipsychotics. And then some genetic studies that have been done, it reveals that TD is associated with polymorphism, which just means variant forms of genes. For example, the dopamine receptor genes and the dopamine transporter genes. So this is good evidence to show us that there is association between TD and dopamine. And then lastly, mechanism of action of the VMAT2 inhibitors. We will get to the medication discussion in the treatment part of the slides. This is the only pharmacological treatment with strong evidence of efficacy in treating TD. Now, the question remains, why TD is often irreversible even when the antipsychotics are stopped. So that is where other theories come into play, which could explain the irreversibility of TD in certain patients. So we have GABA hypothesis, which means the long term of use of antipsychotics will cause damage to GABAergic neurons in a part of brain called the striatum. Since GABA neurons are inhibitory, if they are damaged, they become less functional, and the balance between the dopamine and GABA is dysregulated. This will lead to an imbalance in important circuit of the brain, which plays role in regulating movements. These are called the direct and indirect pathways. However, human studies using GABA drugs to treat TD have shown minimal effects. And then lastly, we also have a theory about acetylcholine balance, which kind of suggests that why being on anticholinergic exacerbate TD symptoms. So this is important to know because I myself have come across quite a lot of patients who have diagnosed TD and they are still on anticholinergics, benztropine, which should not be the case. If you have formally diagnosed TD, you should be off of anticholinergics because they tend to exacerbate the TD symptoms. And with that, I will hand it over to Dr. Nazir.
Thank you, Dr. Asman. All right, so yeah, Dr. Asman sharing the screen. So yeah, I'm Dr. Nazir, by the way. I'll be talking about the epidemiology and the burden of tardive dyskinesia as it is in the US. We can go ahead. Yeah, so around 600,000 of people in the United States are living with tardive dyskinesia. So that's a significant amount of people. Of those, about 60% report having a mild case of TD. There's almost 3% of cases that are extremely severe. And these ones that we're talking about would be visibly having the symptoms of TD and not the subtle symptoms that we can see in the mild cases. The average prevalence is estimated at least 20% of all patients treated with first-generation neuroleptics. And of note, 65% of the people in the US living with tardive dyskinesia or TD have not yet been diagnosed. So how do we detect someone having tardive dyskinesia? If you're experiencing, or if anyone's experiencing symptoms of tardive dyskinesia, the doctor may evaluate using something that we commonly use. It's called AIMS, or Abnormal Involuntary Movement Scale. It's a 12-item assessment used to determine the severity of dyskinesia in people taking psychotropic medications. Now, this is a common scale that we use. There's also other scales that are being researched upon. And again, this one is mostly focused on the severity of the tardive dyskinesia symptoms, but there are other scales that talk about the impact of tardive dyskinesia, impact on individuals' lives. Okay, so AIMS, what AIMS really is, this really is AIMS. Thank you, Dr. Asmat. We usually assess for facial and oral movements, and it is clinician-based. So the severity could be minimal, mild, moderate, severe. It is divided into four things, which includes facial and oral movements, extremity movements, trunk movements, and the global judgments. We also need to see if these individuals have teeth or dentures, because that can impact of the clinician's view of how these movements are happening, because a lot of times that could be causing these things. So just to confirm. So facial and oral movements, usually we can go into the details, but I'll just briefly touch on it. TDs, individuals with TDs, we usually see a lot of times they have movements like blinking, puckering, pouting of their lips, biting, clenching of their jaw, and tongue movements. Extremity movements involve arm, wrists, hands, fingers, legs, knees, ankles, and toes. And again, mostly we would see the extremity movements in mild to moderate cases. And then there's also trunk movements, which honestly is mostly seen in severe cases. So really, what else needs to be ruled out? There's multiple things, actually, medical and psychiatric, and I will not go into the details of that, except for akathisia, really. And that is important, as Dr. Osmond was explaining. A lot of times, individuals would be on anticholinergics, and that would be worsening tardive dyskinesia. And also, we do see that increasing the dose of an antipsychotic could worsen akathisia. So akathisia needs to be on the top differential when TDs are being considered. This, the other medical and psychiatric comorbidities is a separate topic. The impact of tardive dyskinesia. Now, these talk about the daily impact that it has on an individual with tardive dyskinesia. Most of these, again, relate to physical impacts, emotional impacts. Physical impacts could include pain and discomfort, breathing difficulties, walking difficulties. The emotional impact could be stress, embarrassment, isolation. A lot of times, individuals with TD try to minimize these when they're in front of people, and that obviously causes them to be stressed, embarrassed, and they're not wanting to go out. And it comes with other psychiatric comorbidities such as depression and anxiety. Of note, 65% of the people with the reported tardive dyskinesia said that their mental health has been impacted from their involuntary movement symptoms, and that's obviously natural. 48% of people living with tardive dyskinesia reported their movements affected their ability to type and write. So really, very strong pattern in physical symptoms. Functional impacts, again, difficulty writing, eating, swallowing, speech problems, sleep problems, and the therapeutic impacts include changes in medications, changes in emotional stability. 37% of the people living with tardive dyskinesia reported that their movements affected their ability to eat and drink. These are some statistics. 64% of people living with tardive dyskinesia reported their movement affected their ability to fall asleep. Well, thank you so much. And Dr. Sev is going to talk about the prevention and treatment. So let him take over.
Thank you, Dr. Nazir. And thank you, Dr. Azmat. My name is Dr. Saif, and I'm going to talk about the prevention and the treatment and eventually the prognosis of the tardive dyskinesia. So for the preventions, first thing is we need to use the antipsychotics carefully. I mean by that, sometimes we see a patient use, for example, Seroquel. This is a very common agent. Some just people use it for sleeping because it's have a very strong side effect of sedation. So this is one of the off-label uses, but comparing the side effects of tardive dyskinesia with using it only for sleep is not an indication, doesn't worth it. So if we need to use antipsychotic medication, we really need to have a very strong indication for it. Another thing we need to take care of to prevent future events of tardive dyskinesia is close monitoring. Close monitoring and frequent reassessment for any abnormal movement disorder can help to early detect and doing early intervention to prevent progression of the tardive dyskinesia. And that really can help to improve the remission rate from tardive dyskinesia from 40 up to 90%. We will talk about this in the prognosis. And also one important thing to remember is even for the patient is never ever stop the antipsychotic just abruptly if you start to see or experience an abnormal movement, because this can worsen the pre-existing tardive dyskinesia. What usually the psychiatrist will do, it will start gradually to withdraw the offending agent and introducing another solution or another agent if needed. And we will talk about this in the treatment. For the next one, in the treatment, yes. So we will speak about the lines of the treatment. So for the treatment, we have 3 lines. Mainly, we first will try as possible to gradually withdraw the medication. So if we have an antipsychotic and the patient can live without it, or the patient doesn't need, there is no a very strong indication for this medication, we can try to either decrease the dose or gradually withdraw that medication if possible. What if not possible? So we'll try to switch from a very strong agent like first generation antipsychotic to a second generation antipsychotic, which they are less potent dopaminergic antagonists. So for example, we switch from haloperidol gradually to, for example, clozapine. And well, okay, so we did this, and the patient still had the tardive dyskinesia. So we try to introduce some evidence approved agent like the adjuvant agent like VMAT receptor inhibitors. Those are the only FDA approved medications for tardive dyskinesia, the VMAT receptor inhibitors. Like valbenazine and deutetrabenazine. I'll try to simplify this complicated diagram, but let's just say, the main concept for tardive dyskinesia is we have the main theory, the main acceptable theory is we have dopamine hypersensitivity, right? So we have two ways to control this hypersensitivity. Either we decrease the dopamine production, the monoamine, which is dopamine, or either we try to block the receptor, so even if there is a lot of dopamine, they cannot work on the receptor. So VMAT work on the first solution, which is decrease the production. Let's just think, it's from its name, it's called vesicular monoamine transferase or transporter. It's transport the dopamine from inside the neuron cell to outside the neuron cell to start working on the other neuron cell. And what is this medication is doing is decrease that transporters, kind of hinder moving this transporter from inside to outside the cell, and eventually that's will lead to decrease the production of dopamine or the excretion of dopamine from the neuron cell to outside the cell. This is merely the main concept of this theory. So by this, it will decrease the hypersensitivity to dopamine. We have another medications like multivitamins, vitamin E, vitamin B6, melatonin. None of these have a strong evidence, but sometimes we can use it to control the movements. Also, we have another medications in the next slides that doesn't have a very strong evidence, but we usually start with the high evidence, and we can add another medication if it's not well controlled. The highest evidence medication, as we said, is the VMAT receptor inhibitors, and clozapine, one of the medications that sometimes be used and have a good response to control the TD, the tardive dyskinesia abnormal movement. The ECT, TMS, and deep brain stimulation, all of them have low evidence till now in controlling or improving the movement disorders. So for the prognosis, sometimes usually the tardive dyskinesia is often reversible. And as we said, the remission rate improved from 40% up to 90% with early detection and assessment of younger patients. Those are already on the antipsychotics, and the early intervention. Usually remission takes 3 months, and it can take up to 3 years for a complete remission of the tardive dyskinesia. However, what if the patient does have to be on antipsychotic treatment? We don't 100% sure what are the prognosis, but the prognosis for the patient who has to be on the tardive dyskinesia, who has to be on antipsychotic medications and have tardive dyskinesia. If the tardive is gonna improve, we are not sure, but what we know that if it's already established tardive dyskinesia, it will not be worsened if the patient continued to be on the antipsychotic treatment, if needed, of course. So for the next one, I think this is the last one. We have some myth and facts about tardive dyskinesia. Is the antipsychotics are the only medications that cause tardive dyskinesia? No, there is, as we mentioned before, there is anti-emetics and antidepressant. There is multiple categories that also can cause tardive dyskinesia. So is it a rare disorder? No, it's not uncommon disorder. The second generation antipsychotics doesn't cause any tardive dyskinesia. No, this is a myth. Second generation associated with low incidence of tardive dyskinesia, however, because they are less potent, right? The first generation are more potent dopaminergic receptor blockers. So the second generation, can cause tardive dyskinesia, but this is less frequently than the first generation. The tardive dyskinesia is a permanent disorder and cannot be treated. No, this is not true. There is several ways, as we mentioned, and several lines that we can use to treat and to manage the tardive dyskinesia. The last one, and I think this is one of the most important one to be aware of, the people that are developed tardive dyskinesia and are using antipsychotic treatment, should they stop the medication abruptly? No, they should, after reaching a psychiatrist, they should gradually withdraw the medication and not stop it abruptly, because it can worsen the pre-existing movement disorder. This is the website for the resources. Talk about tardivedyskinesia.com. If you need more information or more resources to read about, you can reach this website. And these are the references. Thank you. And I will leave the mic with Dr. Trevino and Dr. Ali.
I think up next is Dr. Ali and Athena.
Yes.
Yes. Thank you, Brad, and NAMI for putting all of this together, and Athena as well, especially for agreeing to participate and willing to share your story and your experiences with us.
Thank you.
Of course. Athena, I just wanted to start by if you can tell us a little bit about kind of your understanding of tardive dyskinesia and what your understanding was, I guess, prior to getting the diagnosis, and if you could talk to us a little bit about kind of the timeline.
Well, it's interesting. I have been diagnosed now for probably close to 30 years with a mental health condition that required antipsychotic medications. And TD was not prevalent or not in the conversation with my doctors at first, even though I was on first generation, and I apologize if I'm not using the right lingo. I'm not a doctor or a therapist, just a peer, fellow peer. And at first, I wasn't having really any issue with that, because my most important my primary goal was to gain control over my life and over the conditions that I had been diagnosed with that were impeding my ability to have the life and the quality of life that I wanted. It wasn't until my late 30s, 40s, where I started showing signs of involuntary movements in my face. And I was showing certain signs, as Dr. Azmat shared, about the facial features or the facial movements being involuntary. And at first I was like, okay, what exactly is this? Because no one was really, again, talking about it. And when I would bring it up to my regular doctor and my psychiatrist at the time, they didn't have an answer for me, which really kind of surprised me even back then, though I believe we really didn't end up with any kind of medication to remedy severe cases of TD until about 6 or 7 years ago, if I remember someone sharing with me. So I was really naive, Dr. Ali, about what exactly TD was until about 6, 7 years ago when I found a new doctor who was helping me treat my condition with the newer generation of medications. And we started talking about, well, she noticed actually shaking in my hands, sort of not feeling comfortable in my own body. There were signs of that. And also, my lips were becoming pursed. I don't know how you say that word, pursed and showing pursed, right? And I started sharing with her some experiences I had with them, and we proceeded to start talking about it.
Yeah, and I was going to say first, you did get the terminology right. First generation antipsychotic, you nailed it. In terms of, the awareness of tardive dyskinesia, like you mentioned, your primary care doctor wasn't aware of it at the time. I feel like for me, that was one of the reasons why, I wanted to be a part of today's session, because I do feel like the importance of, awareness for primary care physicians, for other providers is really important. Um, and some of like, the signs and symptoms that you talked about are the ones that, we tend to see when we first start seeing those symptoms appear. The facial movements, the lips pursing. Um, Outside of, the lack of awareness, I guess like at the time, did you ever feel like there was a delay in care or an escalation?
As soon as my doctor noticed these movements in me, we talked a little bit more, if I can go back a little bit, about some examples of when I actually had started becoming very embarrassed. And there was a lot of stress caused by that, like Dr. Nazir shared about these sort of outcomes of having uh, the diagnosis of TD. She escalated it right away. She did start off with an off-label medication. And I was actually very impressed that I think Dr. Seif shared about some of the things that can be used as alternatives. And compliance was so imperative for me because of the severity of my diagnosis, my mental health condition, that was really destroying my life because of another condition that I was showing, which was anosognosia, which I'm sure you're familiar with that word, being in the presence of other doctors. And I I went ahead and I proceeded to go ahead and take the medication that she had suggested, because still it was very new. The two prescribed medications are now available on the market to help with tardive dyskinesia, especially the severity that you see in people, unlike myself, where I'm 60% of the mild cases, as they say, as Dr. I believe Nazir shared. And I also just felt it was imperative because there would be examples. For example, I'll share, I'd be walking, I would be walking, excuse me, with my mother, and she would notice this uh, tightness or rigidness in my hands, my inability to walk like a normal, like I would normally. Um, uh, Beforehand, before I started getting consistent and compliant to my antipsychotic medications, as well as antidepressants, which also can cause TDS. Dr. Asmat shared. So I also remember a time when I was in an interview and I couldn't stop shaking. And it wasn't necessarily nervousness. It was definitely a different kind of movement that I was not familiar with. And so my doctor, Dr. Davila, we decided to go ahead and give it a try, to try the off-label because she was more concerned about keeping me compliant in my antipsychotics. And I don't know what the percentages are or what the research shows, but being compliant when you have more medications on board as your cocktail, it makes it harder to stay compliant. And it was just absolutely essential for me, and again, for the quality of my life to do that. So we started off with that, and we went from there. I hope I answered your question.
Yeah. And it's always, I think, like you mentioned, kind of a balance, it seems, with treating the primary like psychiatric diagnosis with the medications that we're using, and then, the risk with all of the psychotropic medications, whether, like you mentioned, it's antidepressants or antipsychotics, the risk of tardive dyskinesia. Did you ever feel like, I know for us, like for clinicians, one of the things that's been kind of difficult is sometimes getting the medications approved. Is that something that you had dealt with or that your provider dealt with?
She never went that far, except for she did provide me samples of the existing medications, which I have heard. I've had the privilege of being in Washington, D.C. with the National Association for Tardive Dyskinesia, um, speaking about these things and the importance of these medications being available to people who have the severe cases where it's actually affecting their organs, and things like that. So I never really dealt with Dr. Ali, the resistance from say, the insurance companies, or being, I was put on these samples and I was not responsive to them. The tardive dyskinesia continued, the symptoms were still there. So we decided to go ahead and try some alternatives that I continue to use now, certain behavior adapting certain habits, things like that, to help me with when the stress is triggering it and things like that. And we probably will talk a little bit more about that in your additional questions.
Yeah, kind of actually like on that point, like, do you feel like, I know you've talked a little bit about how tardive dyskinesia, has made an impact or it's kind of changed the quality of life. I know that's something, I've definitely seen with a number of our patients. Sometimes like movements getting so severe, that's led to like difficulty with swallowing because of like patients developing tongue hypertrophy. Um, do you feel like in terms of like how it's impacted your quality of life, in what way do you feel like you've been supported or you've been able to manage or treat those things?
Well, the good news is I have the privilege of working for the National Alliance on Mental Illness, the state of Colorado. And Ray Merenstein is a big advocate, my executive director, who has been on the Hill advocating for these things. So he is particularly sensitive to my condition, and the fact that it has exacerbated my stress levels. You're embarrassed. Again, I hope it's okay, Dr. Nazir, that I use your words. Isolation, those kind of things happening. You don't want to go out. You feel not so confident. I do these kind of presentations about mental health and tardive dyskinesia because I want to step myself. I have to force myself out to get past what people are going to be thinking if they see me get tense around, my facial features, or not my features, but my movements becoming different when I'm talking. I have to take a step back and make my own personal accommodations so that I don't put myself in situations that could make it worse for me, or make me feel incapable of doing my job or having relationships or any kind of interaction with other people or situations. So I would say that I get a lot of support from my employer because that's what we're in the business of helping people, advocating and educating people with mental health conditions and conditions that develop from the medications that they may be on to help themselves and, excuse me, to develop a quality life.
Yeah, no, it's really great. I know like the work that, really glad that you work for NAMI and, to get like that firsthand experience with this kind of organization in terms of like how helpful and how supportive they've been. But it also sounds like you have been able to develop a lot of those skills and kind of behavioral modifications and ways to kind of develop those coping skills, which is really incredible. I think you've done a really like fantastic job at that. And it kind of leads me to, one of the other things that, we talked about in the past, which was, nowadays in psychiatry and medicine generally, we try to take more of a, holistic approach to the way we treat our patients. So it's not just always about medications, but also making sure that we're addressing, the mind, the body, the soul. In what way do you feel like you've been able to kind of that either your provider or for yourself, like what kind of things do you feel like you've done or that for tardive dyskinesia or even just generally for your mental health?
This is my favorite subject, Dr. Ali. We had the privilege of speaking prior to this presentation. And if there's one thing that I strongly believe in is the holistic approach to taking care of someone and taking care of yourself. I too believe in the mind, body, soul, spirit, depending on your belief system. But there's no denying that we're a complicated being. And I, for one, feel that it is absolutely essential. First of all, physiologically, is that the right word when you're talking about medications for the mind, so that the chemicals can work properly together so that we can regulate serotonin, dopamine, and all the chemicals that are in impacting a person who has a predisposition to a mental health condition like myself. And then physically, I go out of my way to practice yoga, walking, and I also bring in the importance of aerobic activity to make sure that I'm contributing to the healthy chemicals in my brain, in my mind, in my body to help regulate stress, which for some reason I find seems to play hand in hand with the physiological impact of TD on me. And so, and then spiritually, I hands down, if it wasn't for the God time I make in my day, specifically starting off in the morning with just doing my mantras, doing my meditations, doing my prayers, even reading certain scriptures or literature, anything that I can get my hands on from all spectrums of religions and things like that, and what works for me personally. So I thumbs up for anyone who sees that. Dr. Ali, I commend you that you bring that up and you brought it up again today, that it's essential to treat the person as a whole being, because I had doctors who did not recognize that. And I think one of the reasons I struggled with my compliance because I was not, those aspects of my being were being neglected in the conversation. And so the doctors I have a wonderful doctor, Dr. Sadaf, or nurse practitioner Sadaf, who has a psychiatrist who works with her, who sees me as a whole being. I have bipolar disorder and I have complex PTSD, and they feed each other. And so when I get triggered, it kind of puts a chain reaction in place where I have to say, wait a minute, okay, first of all, we're dealing with a trigger. We're also dealing with how the trigger is feeding into my mind's chemistry and the importance of regulating that the best that I can. Again, I'm not a doctor, I'm not a therapist, but having had a condition for 30 years, you sort of kind of pick up from your doctors, your wonderful doctors, and the doctors who needed to be educated. And nowadays, That's absolutely essential for TD to be something that the doctors speak of, who share with their patients who may not even be showing those signs, so that you can discuss the regimen that's necessary to take care of the mental health condition, and at the same time possibly prevent, or if they're showing signs, as I think Dr. Steve said, reversible or put in remission.
And I was going to ask you, maybe some other time you can share some tips, some yoga tips with me.
I'd love to, Dr. Ali.
Yeah. Um, Athena, just last question. Is there any advice that, you would give to me or the audience or, providers in general? Anything in particular about your experience with tardive dyskinesia?
I would just simply say, keep doing what you're doing, guys, because if you're out there sharing and talking about it and having compassion and passion for your patients and the people that come to you for help, please continue educating the public and advocating and supporting the people that are coming to you with these types of symptoms. That there's a lot of fear and and stigma. We're still battling the stigma and the fear that's out there. And to my peers, anyone who's online who happens to be a fellow peer of mine, don't quit, don't stop. Insist on thriving, not just surviving with your conditions, because that is essential to the quality of anyone's life. To not quit on themselves, whatever it may be that you're battling with behind closed doors, whether it is a mental health condition or not, whether it is TD or not, tardive dyskinesia, or both, that there are doctors. Here we are with a panel of doctors that came out, that stepped away from their busy schedule to share and provide information to us about a very, very important subject that's impacting the community and my fellow peers who are out there, over 600,000 people, many of whom are not even aware of what's going on. I didn't even know. So thank you that you took the time to ask me these questions, and I thank the panel and you, Dr. Ali, that you and Brad, who is on the line, who put this together with the Texas University Health Science Center. And thank you.
Well, I just wanted to say you're done such an incredible job, I think, advocating, for our patients. It's really an inspiration. Thank you so much for being so vulnerable, open, and like sharing your experience with us. I know it's been incredibly helpful for me and the rest of the panel, and I know for our audience too. Thank you.
Thank you.
And I think with that, we'll also open it up to any questions for myself or for the rest of the panel.
Should be a Q&A feature that you see there in Zoom. If anybody would like to ask a question, you can do so now. Dr. Log, I know you had a few closing comments. If you want to offer those now, and then if we have any questions come in, we can address those after.
Absolutely. Thanks, Brett. So I really wanted to thank Athena for sharing your personal journey about tardive dyskinesia. And like Dr. Ali said, I want to express our deepest gratitude for your willingness to share your story and for your ongoing advocacy efforts. What I wanted to say is your voice is really powerful force for the change. And we are truly honored to kind of have you here with us today. So thank you once again for doing this for us. Yeah, thanks. And as we kind of conclude our discussion on tardive dyskinesia awareness, support, and help, it's pretty evident that education and coming together is pretty important in navigating this condition or any mental health condition in general. And our today's goal was really providing education and helping our people in the community to kind of understand what tardive dyskinesia is all about. And in this journey, as I was kind of working through the wonderful presentation that my trainees put together, there was a little quote that came across my mind. I wanted to kind of just say this out loud to each of you here, is that when we give cheerfully and accept gratefully, everyone is blessed. This is not a quotation I came up with. This is, of course, something that I found online. But these words specifically kind of hold importance and very much significance, I feel like, in the tardive dyskinesia community. What it really means is we emphasize the profound impact of empathy and assistance. And, you know, we kind of utilize all these technology, and we're trying to find a solution to support our patient population for the ones that are affected by tardive dyskinesia. So all that we request, the individuals that are here, the patients themselves, their family members, their friends, every single person in the community, to do so with a spirit of compassion and inclusivity. Once again, I want to thank each of you for your engagement and commitment to making a difference in the lives of individuals with tardive dyskinesia. I wanted to give special thanks to our amazing Brad Hunt from NAMI Lubbock and his team for all that they do. And then a very special thanks to our phenomenal Dr. Trevino for her unconditional support as always, and for bringing the two platforms, NAMI Lubbock and Texas Tech University Health Sciences Center, together and making this possible today. Thank you.
Absolutely. We do have a question in the chat, so we probably have time for this one and maybe a couple more if they come in. This could probably be answered by Athena or anybody on the panel. How would you advise caregivers to encourage those who are affected by TD to seek help?
I don't want to, I'll just go ahead and just go for it. I think if anyone comes to a session, I'm able to see my doctor pretty regularly. So we're able to keep an eye on things when my medications need to be adjusted or there's something that needs to be changed at all. Just discussion. Again, any new developments when it comes to tardive dyskinesia through the community, through the physicians that she speaks with and her fellow peers. I would just say continue doing what you guys are doing. And as I shared earlier, I think that it's just essential to be discussing it with your patients ahead of time before they're put on a medication, so that there's a discussion over who and what medications could be considered. But I'll leave it for the doctors and to share possibly.
So I'll probably go ahead and answer this. It's a great question. So, you know, definitely educating not just the individual who is going through it, but the family members about tardive dyskinesia is extremely important in terms of the condition, the symptoms, the causes, the treatment options like we talked about here. Validating their concerns, kind of acknowledging the challenges and the emotional impact of caring for the loved ones who go through it. And encouraging open communication is really important. So kind of creating a safe space for the caregivers to share their experiences and feelings without the fear of judgment, which is extremely important in any kind of mental health problems. And then connecting them with the resources like NAMI itself that we're here for. And then there's another association, which is the American Parkinson's Disease Association, which is also pretty amazing. There are online support groups and forums. Their local mental health professionals experienced in tardive dyskinesia management could also be very helpful. And then there's support treatment, kind of exploring that with them, that what more could be done for them. And then also finding some specific specialists, like specifically neurologists, psychiatrists. There's specific physicians who have training in movement disorders, and that they have expertise in, like I said, tardive dyskinesia. And then emphasizing on self-care is extremely important. I think I had done a presentation for NAMI Lubbock a couple of months ago on self-care, kind of encouraging caregivers to prioritize their own physical and emotional well-being, like taking breaks, and kind of seeking care for themselves when needed, and not just entirely focusing, because you can't really serve from an empty vessel. So once you feel better is when you can really take care of other people who are not doing as well around you. And last but not the least, kind of reminding them of their importance, like kind of emphasizing the vital role of caregivers and the support they provide to the loved ones who are suffering. So this is what I would probably suggest. I hope this kind of answers, unless others on the panel have things to add to that.
There was one additional question that came in about looking for resources that they could pass out. And I've answered that question in the chat, but just to answer it verbally as well, I do have a bunch of one sheet sort of summary information about TD, and I've got 150 or so copies. I'm happy to provide those to anybody that would like them. I've put my email there in the chat, leader@namilubbock.org, and I can get more materials if needed. So just let me know if you'd like some to pass out at a table or have some in a clinic, anything like that, we'd be happy to provide those. A couple of other questions here in the last couple minutes we have left. One says, I came in late, so I apologize if you went over this. A quick Google search says Black people are more at risk. Why is that? Anybody want to take that one?
When I was going through the risk factors and all, I did come across this factor, but there's no like specific explanation as to why the African American population would be more prone to that. It's just based on the statistics, that is the data after researching on patients with TD. So this is just a demographic, but I don't have like exact pathophysiology or an explanation to explain why are they more prone.
And I think, I'm sorry.
Yeah. No, go ahead, Dr. Nazir, if you want to add something.
Just to add to that, as Dr. Osmond had initially explained in her slides, that there's multiple factors that lead to TD. One of those was also related to genetics. And I think that this is a wonderful question in the sense that this could be researched upon in the future, why they are more prone. It's probably because of their genetics. It gives us an idea.
One thing I would just like to add, overall, we have more incidence and prevalence of mood disorders in the African American population. So they are, there's a high chance that they are on more psychotropic medications as compared to general public. So that kind of increases the risk if you are using psychotropic medications.
Also to add to that, Greg Hanch, who's the executive director of NAMI Texas, is on the call today, and he commented that African American population is more likely to be prescribed older antipsychotic at higher doses. So that's an interesting thing to know as well.
So that's pretty awesome. That's exactly what I was going to say actually here, that with African American population, actually, they get disproportionately diagnosed with schizophrenia, which actually increases their risk of developing TDs, because they do get, when you get diagnosed with schizophrenia, you do get prescribed neuroleptics or antipsychotics. And the more antipsychotics and the higher dosages you're on, you're bound to have higher chances of getting TDs. And then also, like, they receive long-term antipsychotic treatment, which again kind of increases your risk. And also kind of the rate at which they metabolize antipsychotics is pretty different. And usually the studies that we have are more on Caucasians. I always mention this to my Asian population as well. So the dosages at which we start our Black population is probably higher, and they probably require lower, so they end up having more side effects in terms of tardive dyskinesia. So just kind of a couple of those bullet points out there, and kind of agree with Greg, what he mentioned. Yeah.
Well, we are at our time for today. So again, thank you so much to everybody for attending today. Thank you to our presenters for giving of your time and talents. And thank you especially to Athena for sharing part of your story with us. Again, watch your email for a link to the survey. It looks like it was also just added to the chat. But if you can complete the survey, that helps us know topics to cover next time, and helps us to know how well we did today. So thank you very much for attending, and thank you all again. Have a great rest of your day.
Thank you.